All right, so as everyone's getting in and getting ready, I just want to welcome you to our presentation today on pain in the brain, addiction and alternatives to treating chronic pain. Today we have with us Dr. Mark Bailey and Dr. Burl Gooden. And right now I'm just going to go through a couple housekeeping things regarding how you guys need to go about completing the evaluation, and then how you will collect your continuing education credits. All right, so just some continuing education information. This has been approved by the Alabama Board of Social Work for 2 hours, the NBCC for 2 hours, and the Alabama Board of Nursing for 2.4 contact hours. All right, so to go about collecting your continuing education credits, what you need to do is you need to change your name in Zoom. So you'll go to the 3 little dots by your name and just click on rename, and then rename to the name that needs to be on the certificate. So after the end of the presentation, on what is called the post attendee page, which I'm sure you've all seen on Zoom, which is typically like the web page that pops up when Zoom closes out, you are going to have the evaluation pop up, and then I'm also going to put the evaluation link in the chat box as well. You'll need to complete that evaluation in order to get your credits. And then in just a second, I'm going to show how you'll collect your continuing ed credits, which you will do through clicking on a link at the end of the evaluation, which will take you to another page where you'll fill in your continuing education information. You should have your continuing ed credits by September 14th. I typically say 7 days. I typically have them to people in just a couple of days, but 7 to 10 days just to give me a little bit of leeway. And then if you have any questions, if you'll just contact CE at APC BHAM, then I'll get back to you as soon as I can. All right, so on this page, this is what will pop up at the end of the evaluation. So at the end of the evaluation, you're going to click on the other SurveyMonkey link, and that is going to take you to the CE request. And then there you'll fill out your continuing ed information. All right, and then here you'll see that we have some upcoming trainings happening in September and October. They are not able to be registered for yet. I think the registration link opens for those in, let's see, 2 or 3 weeks, but they'll open 2 weeks ahead of time for all of the presentations. So like the one that is on October 14th will open on October 1st. All right, and then we would just like to thank, of course, APC, which is who I'm with, the Drug Education Council, CAPI at UAB, and then Not One More Alabama for helping us put on this presentation. So first, getting started, Dr. Bailey, can you go ahead and introduce yourself, and then Dr. Gooden, and then Dr. Bailey, you can start with your presentation.
All right, let me see if I can get screen sharing to work here while I'm fiddling. Let's see. No, I don't see it. The screen sharing is paused. Why would I do that? Resume sharing. Okay, there we go.
All right, we can see it.
All right, you guys can all see that. Let me see if I can actually, there we go. All right, that looks pretty good. All right, I'm Mark Bailey. I appreciate the opportunity to talk to you today. I am a neurologist by training. I'm board certified in both neurology and pain medicine, and I do medical pain management at UAB. My office is at Highlands. I don't stick the long needles in folks. That's my brethren up here that do that. I typically do the medical management, and that's what I'm going to be talking about today is some sort of current ideas concerning pain management. The objectives are I'd like to increase your awareness of the scope and magnitude of chronic pain in the general population. I would like to explore the extent and trends of the current opioid epidemic. I'd like to consider various treatment options and underscore the increasing importance of non-pharmacologic pain treatment modalities. That last one represents a huge shift in the thinking of the pain community, and that's what I want to try to get across. Okay, this guy here is my helper. This is Dr. Simon Bar-Sinister. He's the patron saint of UAB Neurology, in case you guys didn't know. He's clearly a neurologist. He's got a long white coat, a bow tie. Sometimes he carries a Tromner hammer. He's going to help me. So this is an old slide. I don't remember exactly what year this is from. It was several years ago, but the idea is exactly the same. There is a lot of chronic pain in our population. In fact, in the medical group, there's more chronic pain than there is diabetes, heart disease, and cancer put together. So that's an awful lot of people who suffer with chronic pain. It's about 20%. I mean, there's all kinds of different breakdowns of who has chronic pain and who has what's known as high impact chronic pain. I have some demographics here with the breakdown, but older folks, age 65 and older, tend to have more non-Hispanic whites, more likely to have chronic pain than non-Hispanic blacks or Asians. And the incidence of chronic pain becomes more as you move out of the cities and into the rural communities. Here's that breakdown I was talking about, the percentage of chronic pain of people with both chronic and high impact chronic pain. And that's a whole lot of people. I mean, 20% of the population is significant no matter how you slice it. A lot of people with chronic pain out there. This is 2019 data here, so fairly recent. Now this is another breakdown of from the Academy of Pain Medicine. This one's a little more recent, but this doesn't really reflect what my patient population looks like. The numbers that are mentioned here, chronic pain from 560 billion to 635 billion, and this is in 2011. I don't, my eyes get crossed when I start thinking about numbers that big. So it's a whole lot of money that gets spent on chronic pain, not just on expensive pain doctors and MRIs and stuff, but also in lost wages and lost productivity. The common causes of chronic pain on the little graphic on the left, I don't know, mine is skewed real heavily toward back pain. Like I said, I'm a pain doc, and back and neck pain is the vast majority of what I see. Headaches, we've got headache specialists that I guess mostly get those. Face pain I see some of, but most of what I see is back and neck pain. Okay, these are the harsh truths in the chronic pain world right now. We do have an opioid overdose epidemic in the US. And when we say opioid epidemic, that's usually what we mean. The metric that we use to measure that is overdose deaths. 33% increase in the last 5 years per CDC. That has been skewed somewhat by the COVID-19 business, and I'll show you some more data on that in a minute. It's mostly synthetic opioids like illicit fentanyl that are driving this up. And we're going to talk more about fentanyl, but that's really where the action is. Heroin is up some. Our old friends, hydrocodone, Lortab, Norcos, et cetera, they're pretty flat right now, maybe even decreasing on some studies. But mostly it's fentanyl that's the bad boy here. This is a little fun fact that I'm not sure I can truly explain to you, but US citizens are about 5% of the world's population, yet we use 80% of the global supply of opioids. Now you could say that, well, maybe it's a availability thing, that there's probably places in the world who couldn't get a pain pill if they wanted one no matter what. And that's true, but I don't think it accounts for that huge disparity. I think the folks in the US use a lot of pain medicine. The bottom point down here is one that is absolutely true. And it's our patients want a pill for everything and seem minimally willing to participate in their own healthcare other than to take more pills. And that is true. And that's going to have to change if we're going to see this overdose epidemic turn around. People are going to have to decide that something other than one more pill is what they're going to have to do. Okay, so this is overdose deaths, and the black line on the top is the total. And you see the timeline starts in about 1999. And at that point, the public perception was that doctors were not writing enough pain medicine, and we were letting our patients die in pain, and something had to be done. There were political involvement, and we got some guidelines and guidance and federal laws. That's about the time that JCAHO decided that pain was the fifth vital sign, and that we had to keep up with it more closely. So doctors started writing more pain medicines. That's true. That's what we did. And as a result of more pain medicines being written, since mostly the prescribed opioids were what were out there and available by diversion typically, we saw more overdose deaths. And then in around 2010, the perception had changed, and it was that doctors were writing too much stuff, and that they had to start cutting back. Well, I'll show you another graphic in a minute. They did, but then the drug of choice started to shift. It shifted away from prescription drugs to more street drugs and illicit agents. And then as time moved forward, it says synthetic overdose. Mostly we mean fentanyl is the chief player now. Heroin and other commonly prescribed opioids, you see the blue lines toward the bottom there. They're flat or even decreasing a little bit. I think this is arguably one of the most important slides in this whole deck. The green is the amount of pain medicines that doctors write. And again, same story, 99 to 2010, doctors were writing more medicine. Public outcry, doctors are killing people with all their evil opioids, something has to be done. So we did. We started writing less pain medicine, and that's where you see the green line tapering off up there. Well, obviously the idea was to decrease the amount of overdose deaths. Well, as you can see from the black line there, that didn't happen. We switched drug of choice, and it changed from prescribed medications to illicit meds, fentanyl and heroin being the two major players, and the overdose death rate has just skyrocketed. So what I would propose to you is that regulating the hell out of the docs really didn't produce the desired effect here. Just throw that out there. Here's the states that are highest in overdose deaths. And this is from the CDC Wonder pages, and it was supposed to be updated this year, but I just checked this few days ago, and they have not updated it, and Alabama is not reporting on this thing. I don't know why that is, but you can, if I had to guess, it'd probably be somewhere around the Mississippi or Georgia numbers as far as deaths per 100,000. You see the hot spots there. The black numbers, the Appalachian states are real high. New England is real high. I mean, that's where this is supposedly recent data. Again, I can't explain why Alabama is not reporting here. Okay, let's get a little closer to home. Jefferson County, the Jefferson County coroner every year produces this astounding array of data and charts and graphs and how many people overdose. Really impressive. And this is this year's or last year's numbers. So you can see the overdose death rates went up in 2020 as compared to previously. We were thinking they were going down, and maybe this was a good thing. And we were kind of patting ourselves on the back, but then this year it's gone up again. This is the drugs involved in the overdose deaths. This is from the coroner's tox screens. And the only tricky thing about this is that each individual patient may be represented multiple times. So if the patient had fentanyl and Xanax and, you know, some other agents, it would be counted in each of these columns. So as you see, the fentanyl one is the bad boy here, as Dr. Barsinister is indicating. The other one is alprazolam or Xanax. That's the big one. I don't think the antifreeze got on this list. It was on the list for a while, but I think we've not had any deaths from antifreeze intoxication in a few years. I guess that's a good thing. And this is how the coroner changed the way that they represented the geography of where the overdose deaths were. This kind of weird psychedelic colors. I'm not sure why, but Dr. Barsinister is indicating downtown Birmingham there. And let's see, I think you guys can see my cursor. Here's the airport out here. So it's a little denser out by the airport. But this is where overdose deaths are happening in our geography. Kind of follows the interstates. That's not, I guess, big news. More population centers, more overdose deaths. Again, not surprising, but that's what we had. So what's going on with the overdose deaths rate in the COVID-19 period of time? Well, it's gone out the roof. As it says here, the CDC issued a health advisory saying that the overdose deaths have soared to the highest number ever recorded in a 12-month period. And this was ending, I think, March of this year. This was before the variant COVID slapped us in the face and took off again. So this is last year's data. The more people were dying of overdoses during the pandemic. Here's the graphical representation. The dark bars are the 3 months, April and May and June. So as you see, we're having more overdose deaths. I don't know, people staying at home, getting pushed closer together. I can't explain that, but clearly during the pandemic, overdose deaths have increased.
Dr. Bailey, this is Ellen. I apologize for being late. I wanted to say hello quickly to the audience. Sorry, I had some IT issues, but I thought it might be a nice time just to pause because I know that several of our panelists had some questions they were going to ask of you as we're going, and maybe even respond if there are any relevant questions in the chat at this point. I just wanted to ask of you and also of Edward. I thought it was really interesting, your observation that a lot of your patients are interested in a pill. And I see this in my HIV practice. I treat opioid use disorder in patients with HIV, and whether it's anxiety or sleep or energy, it's a lot more likely that my patients ask for a prescription than ask me for my advice on, for example, how to sleep better. And I agree with you. It seems like really this cultural expectation that we have a pill to treat everything. And I'm curious from Edward's standpoint, how you think that may or may not be a product of really this substance use epidemic we're seeing, and maybe how that may be different or more prevalent or less prevalent in the substance using community to want a prescription for some of these very common symptoms and complaints.
Yeah, sure. And my name's Edward Taylor. I'm the prevention program coordinator for the Addiction Prevention Coalition. I am in recovery from heroin addiction, which no surprise started with prescription opiates. And I'll actually have 4 years clean and sober tomorrow. And I also have some experience with chronic pain, several surgeries or 2 surgeries on my spine. So to answer your question, Dr. Eaton, I'm not really sure, the connection between those two. If I had to just take a guess. I mean, it's, well, I don't really know, to be honest, but I do think that one big concern that we have is that that unused supply of opiates that sticks around when patients they don't mean any harm, of course, but they just forget about that they had this bottle full of prescription opiates in their cabinet, and then that kind of goes on and on and on. But I can say that in my experience, when I had my chronic pain issues, I definitely wanted the quick fix of a pill. That's it. I didn't really want to, it seemed like there was more proof for those to work, whatever pill it might be. Whereas if somebody were to come to me with some sort of non-pharmacologic treatment of some sort, I would have been pretty skeptical, and it would have been a hard sell for me for sure, especially if I had tried, say, an opiate that did actually help with my pain for a little bit. Then it would have been a really hard sell for me to try something like Tai Chi or yoga or anything like that.
Definitely a hard sell, and that's really part of the problem. It takes a whole lot longer to convince somebody that their knees are wore out because they're 350 pounds, and weight loss is an important part of what needs to happen. Much easier just to write on the script.
Let me just add something here real quick, because I just want to make sure that all the blame isn't being passed to the patient here in their desire to have a pill, right? America, unlike the rest of the world, is really the only country that has direct-to-consumer advertisements. When's the last time you've seen a pharmacy provider saying, hey, go get you some Tai Chi, right? It doesn't happen, right? But go get you this pill. That happens a lot. The other thing, particularly in Alabama, where there's a lot of low-resourced individuals, but this is across the country as well, right? I say Alabama because, one, that's where I'm at, but also as a non-Medicaid expansion state, there hardly is any reimbursement for things like cognitive behavioral therapy for pain management. So why even bother, right? But it's much easier to go ahead and write that script and get reimbursed as a provider for that, right? So that being said, I understand it is a culture of wanting a pill to fix things, but that isn't just the genesis of that isn't just the patient, him or her or their self.
Yeah, I think that's a great point, and it's often something that we forget, that medications don't fail, our patients don't fail our medications, right? We fail our patients by not having the systems in place and a lot of the additional support that they need. And I wanted to go back to Edward, because I know you had told me that you had a lot of thoughts when you heard about this option to discuss pain in the brain, and I know you've thought a lot about it. But just before we move on with Dr. Bailey's moving on to the pain experience, are there any other thoughts that you really are the expert with lived experience? Any other things that you want us as providers, as support systems, as champions for our friends and neighbors who may have chronic pain and struggle with substance use disorders, or anything else we should know just from what Dr. Bailey has discussed so far?
Not so far. I do have extensive notes, like I told you earlier, Dr. Eden, and I guess a lot of my thoughts will come out throughout this presentation, but for now, I think we're good for now, but they'll come out for sure.
Thank you, Dr. Bailey, for letting us pause. If you want to keep going, we're anxious to hear some more of your expertise on the pain experience.
Okay. Well, obviously the title of the slide is Pain is an Experience. It is the number one reason people seek medical attention. The example that I usually like to give here is because Alabama is such a football emphasizing kind of state. Let's say that it's the day of the Iron Bowl and the score is tied. You've got a lot of interest in one team. It's the fourth quarter. The game is fierce. You've got money on your team. You're very focused on the game. And let's say I sneak up on you with a hammer and bop your toe. Okay, tissue damage occurs at the level of the toe. Neural signals are transduced and conducted by way of the peripheral nervous system to the spinal cord. Some pain processing happens there. The signal goes up to your brain and pain is perceived. And so you turn and shake your fist and say and think naughty things about Bailey and his hammer, but then something happens on the TV, the crowd goes crazy and you're back to it. And it didn't end up being that big a deal. Now let's take it the next day. Your team lost, you drank too much, you're hungover, the weather's bad, your hair's not working, it's a bad day. Now I sneak up on you, same hammer, same toe, same amount of force that I managed to apply. It hurts a lot worse, right? The experience of pain is related to the hammer and the toe, but it's not the same thing. And there's a lot of things that shape that experience other than hammers and toes. And that's the point of all of this, that the milieu, the stuff going on in your brain, and I guess spinal cord too, at the time of the pain perception makes a lot of difference in how much pain we do perceive. There are 3 described pain types right now. 2 of them have been talked about for a long time. Nociceptive is damage of tissues. That's acute injury, broken bones, post-op pain, etc. That one we're familiar with. Neuropathic pain is damage to nerves, diabetic neuropathy, post-herpetic neuralgia. Central neuropathic pain is from strokes to the thalamus and pain relay places, but this is a function of nerves. And then the one that's less familiar to most of us is the nociplastic, which is abnormalities in pain processing. And fibromyalgia is really the prototype here. Hard to find physical abnormalities in fibromyalgia. There are some. I mean, you can do some pretty elegant studies and demonstrate, mu opioid receptor abnormality, binding abnormalities, et cetera, but it's pretty exotic. But the source of the pain is a abnormality in pain processing, not a broken bone and not a injured peripheral nerve. And then there's mixed, which is a combination of some of the or all of the above, which is pretty common. Like I said before, back pain is a lot of what I end up treating. And a lot of back pain is a combination of all 3 of these things. So putting it all together, one thing that we certainly want to do when we treat people with pain is determine a pain generator, what's causing the pain. And then we want to focus our treatment accordingly once we figure out what we think is wrong with our patient. I think it's not a good idea to assume that prior diagnoses and treatments were correct and or appropriate. I think you need to make your own call there. There are probably multiple pain types involved, all 3 of these things. I was looking at back pain specifically when I was writing this thing. So in back pain, nociceptive may be facet arthropathy, neuropathic may be a nerve root compression, and the nociplastic may be a fascial pain component to the whole picture. So it's probably a mixed picture there. So important safety tips. This is what I harp on my pain fellows about the most. Rule number 1, there's got to be something wrong with you. And you need to have that documented in your chart. Stubbing your toe in Walmart 20 years ago does not justify morphine now. And that's silly, I know, extreme, but you get the idea. You need to have a known abnormality and have it in the chart, and it's got to be, the treatment must be justified by the diagnosis. That seems silly. It is astounding the number of folks I get referred to me with no clear diagnosis. They had an x-ray 10 years ago in their chiropractor's office, and he showed them their slip discus, and that's the basis of their Soma, Xanax, and Lortabs for 15 years chronically. That really is not appropriate. treatment of pain. So this is where we are needing to head with our pain treatment, not pills. That really hasn't worked out all that well. We'll talk more about that in just a second. But the other things up here, exercise, acupuncture, yoga, Tai Chi, manipulation, all these things have got pretty good track records. Probably better track records than opioids or pain meds or any of the meds we give out, muscle relaxers, etc. But as somebody pointed out, getting these things reimbursed by our insurance carriers is just about impossible. And if insurance is not covering it, it's essentially not available to our patient. I mean, resources are hard to come by. So treatment options, and again, I was doing back pain when I was constructing this list and just looking at what is evidence-based and what doesn't stack up so good. In the non-pharmacologic section, all this stuff has got good evidence support. Manipulation, therapy, yoga, Tai Chi, acupuncture, CBT, cognitive behavioral, biofeedback, all good. I mean, that stuff works, and there's no questioning that. Getting somebody to go is, as somebody pointed out, that's a tough sell. Especially if they've been on a steady diet of opiates for lots of years. I was astounded when I learned that the VA has all this stuff. I just had no idea that they had all these things available. And when somebody told me that, I was like, yeah, that's great, but those old rascals are not going to go to yoga classes. And I am wrong. Apparently they enjoy these things, and they've actually had pretty good success with all these sort of complementary and alternative treatments for pain at the VA. Well, I'm green envious because I don't have these things available. I don't know where I would send somebody for a Tai Chi lesson if I thought it was going to get, I mean, it's not going to be covered by insurance. I don't know of anybody that covers it, but they are evidence supported non-pharmacologic treatments for back pain specifically. TENS units, no evidence the TENS units help back pain. They used to be used a whole lot. Usually in the past, physical therapists helped us out and showed people where to stick the stickies and how to use the wires and whatnot. But the meta-analysis is that they really don't help non-specific low back pain very much. Pharmacologic, there is evidence that nonsteroidals, duloxetine and topiramate help back pain. It's not strong, but there is some evidence that they do help. Weak or no evidence, Tylenol, muscle relaxers, gabapentinoids, lidocaine patches, it's crummy data that shows any improvement at all with these things. And yet, what do we do? I mean, what options do we have? We ain't got the stuff up at the top that we know works. So we're writing them, Tylenol and Robaxin and, whatever else down here. And all we get is a bunch of side effects from the drugs. I mean, they make people sleepy and goofy and so forth. Opioids, including tramadol, are the last resort and be considered only after all others fail. And I can't stress that strongly enough. That if you're going to start somebody on opioids, or if your patient requires them, then they really need to have failed everything else, because it's just not appropriate to start them on opiates for their non-specific or for their pain period until they failed a lot of stuff. Injections, there's some evidence that epidurals are useful for short-term pain relief, probably not long-term. Trigger points also, if you've got a heavy fascial component, that might help. I don't do a lot of trigger points myself. I used to do more. I have a couple of patients that they, get the Christmas stuff out of the attic and they get themselves all tweaked up, and they'll come in and tell me, well, you put those shots in my shoulders last year and it really helped out. Could you? Okay, fine. So I do, but I don't really know what I'm treating with a trigger point injection. If the problem is indeed a pain processing issue, then what the heck am I doing with, steroids and local anesthetics in the muscles? Other joint injections can also be considered. Okay, now we get away from pure science and get into Bailey's opinion here. More and more opioids must be viewed as a treatment of last resort, be used when all else fails. And I keep going over this, and that's the punchline to this whole thing. Non-opioid treatment is going to have to assume a much more prominent role, and our patients are going to have to buy into this. And both doctors and patients are going to have to buy into it, because it's just so much easier to write them a pill. And this pill for every symptom mentality that both physicians and patients have had is going to have to be modified if we're going to get out of this opioid epidemic. People are going to have to be a more active participant in their own health care. Right now, it's difficult to get people to participate in their own health care. You can go through a long talk about exercise and the importance of weight loss and eating healthy and all these other things. And at the end, they kind of glaze over, and then they look at you and say, okay, well, what are you going to give me though? I mean, that's what I end up hearing. Naloxone rescue, all my patients who I prescribe opioids for have a Narcan nose spray prescription. And whether they fill it or not, I don't know. That's a trickier thing, but I do write prescriptions for Narcan with all my opioids. And the last one is that green slide I showed you earlier. Our present strategies not reducing overdose deaths. It just seems to be shifting the drugs used in the overdose death. So in summary, chronic pain is widespread. It's expensive. There's lots of regulations in place concerning writing of pain medicines. That seems to be growing. Didn't help the first go around. Not sure why we think more regulations is the answer to this thing, but that's what's happening. Patient participation is going to have to become more and more necessary in the current opioids the last resort mentality, and that's the tough one. I mean, that's really very different than what we're accustomed to, and the role of non-pharmacologic treatment is going to have to increase. Okay, this goofy looking thing is a pangolin. I saw this on Nat Geo and thought this thing's just too weird to let them die off. They're endangered. So, you want to Google Save the Pangolin, send them $1, get a t-shirt. I would encourage you to do so. There's my contact information, my email and website and address and so forth. So I'm gonna stop it at that point.
Thank you so much, Dr. Bailey. I know we all benefited from hearing about your experiences and lessons learned from clinical practice. We have a couple of questions, and I was going to get into those, but I also, Edward and I have been in the chat, and he had a few follow-up comments from our earlier discussion. Edward, do you want to speak to those, and then we can address some of the questions?
Yeah, sure. I just, I was going to mention a few things, when you gave me an opportunity earlier to speak on my experience and direct it towards the physicians and the medical professionals here. I would say that whenever you as a provider, suspect that you have a patient that might be struggling with opioid use disorder or substance use disorder, that's a tremendous opportunity for you as a provider. I've had experiences where surely, unless the doctors treating me were just not paying attention at all, every red flag in the book was was there for me, starting to develop a pretty big issue with the opiates they were giving me. but I was never approached about it. And I think it's a missed opportunity for sure. I think that, it seems like a very intimidating situation. It seems like it might be out of your scope, your professional scope, but also, you're there to treat them medically, and any treatment for substance use disorder or opioid use disorder doesn't have a medical component is incomplete. That's been my experience. So, if you have suspicions about your patient and obviously you care about them, I would just suggest that if you do decide to approach them and talk with them, I would make sure you check your intentions beforehand. Don't go in with any sort of judgment. If you don't feel like you can have that discussion with them effectively, then don't do it. But, don't be afraid to do it, because it's kind of like a risk reward situation. Like, if I'm already struggling and I'm looking for somebody to reach out and help me, and you go beyond your fear of offending me and bring up like, hey, I've noticed that you've called 30 times in the last 2 days to refill your opiate prescription that you just got 5 days ago. The risk of you offending me for bringing that up compared to the reward of you actually inspiring me to ask you for help, it's just a rational decision to do in that case. So, and just understand too that those patients, if it is pretty clear that they are struggling, they're struggling more than you could possibly know unless you yourself have experience with it. So as frustrating as it is and as disrespectful or whatever that they may be, your job is to treat them and treat them with compassion and try and help them get better. The ball is just as much in the physician's court as it is in the patient's. So those are the comments that I had, but we can get to the questions now.
Yeah, great. I love that. And I think you're right. I mean, there are definitely patients that I've had a relationship with for a while, and you know them, they know you, and it can be awkward, right? To say, oh, tell me about this drinking, or to probe further once you have that relationship. Because at the end of the day, we all, want to be liked, whether we're the provider or the patient, right? We don't want to disappoint one another, but I think that's a really important encouragement for us to ask the hard questions in a supportive way. But you're right, this is a great opportunity, and we otherwise miss opportunities. So now I'm going to turn to, go ahead.
Let me toss in a counter to that. I would say that getting somebody an addiction evaluation is probably harder than getting them in a Tai Chi class. And this is sitting at UAB. I mean, I see a lot of patients, and very often the question arises, is this a use disorder trying to rear its head here? And I need some help. I need professional evaluation of this. It's very frequently, not once a week, but several times a month probably, that I would like an addiction, or not addiction. I'm trying to wean myself from that term, a use disorder evaluation. And all I can get is a checkbox form from the Alethea house. No professional ever saw them. All they did was ask them, well, you got an addiction problem? No? Check the box. No evidence of addiction here, and send me back that piece of paper. And I'm not saying bad stuff about any treatment facility. That's not my goal at all. I'm looking for help here too, because that's not what I do for a living. I don't know a lot about use disorders treatment. I see red flags, and I need some help sometimes. So, any resources that you guys could help me bring to bear on my patients, I'd be delighted. But it's really hard to get given a use disorder evaluation. If nothing else, just to say your patient probably is developing a use disorder and you really ought to be encouraging treatment. Okay, I mean, I can take that ball and run with it, but I can't get that. I mean, I don't remember the last time I got a physician evaluation for a substance use disorder.
Yeah. Yeah, and I think we all struggle with systems, regardless of where we are. But as Dr. Gooden brought up, I mean, resources in the Deep South, Medicaid non-expansion state, limited public health infrastructure. I think we all struggle with this. So some really great points. And I'm glad we have such great attendance today to really inspire people to help us act on this huge crisis that we're all seeing. Dr. Bailey, I have a question for you that came up from someone on our chat. Would physical pain with lupus be considered nociplastic pain? Nociplastic pain?
Well, I mean, you think of lupus as joint involving as rheumatologic pain, and if a joint is involved, then we probably think that's, like a broken bone, just not necessarily nociplastic. And there's just so much overlap, and it's often hard to separate all this out. People with multiple sclerosis have got all kinds of possible pain generators there. Some of it's processing, some of it is plaques in their brain that, some of it is cord involvement. I mean, there's lots of a very complicated answer, and the rheumatologic disorders are way up there on that list, the Sjogren's and the lupus and the not so much the polymyalgia rheumaticus and stuff like that, but certainly I guess when I think of lupus, I think of joint pain, and I start looking for x-rays that demonstrate joint erosive findings, and if I've got that, then no problem. I can treat that. I can say this person has got lupus arthropathy and it's destroying their joints, or rheumatoid, even more so, their fingers are all crookedy, and I mean, it's not, I got something I can work with then. So
And then,
go ahead.
oh, I was going to move on to another question.
Yeah, yep.
The question about the bar graph that you showed right before the pain experience section. So I think it was the section right before we paused. Dr. Suzanne Fogger asked if you could explain the 4 groups on that slide.
I'll have to have to go back and find what slide we're talking about. This thing.
Yes. If you could explain the 4 groups here.
This is a large study that was including the COVID periods, and it's just got increase in amounts of deaths during those time periods. And I don't have anything much to add to this, that this is death rates during these time periods from various sources, from stimulants or cocaine or opioids, or combined, the one on the left. But the point here was just that the death rates have gone way up during the COVID months.
Great, thank you. And I think we're going to try to make these slides available as well, in addition to the talk, for people who need a little more time to look through
Sure.
the data.
Sure, I think I've referenced everything on the slide itself. So if you want to go look it up, I think the reference is there for you.
Great, thank you. And then Dr. Bailey, and I'd also like to hear from Dr. Gooden on this too, hypnotherapy. Someone brought up in the questions, hypnotherapy being used historically before anesthesia. Does it still have a role, and why or why not? Do you all have any experience with that?
I don't personally have much experience with hypnotherapy, but then I don't have a lot of experience with cognitive behavior. I refer it out for that one because that's an area of expertise. But that's another possible non-pharmacologic treatment for pain. Absolutely, I think that's a reasonable shot. So is acupuncture. So is, pain doctors are pragmatic creatures. I mean, if shaking bones over my patient would work, then Bailey would have some bones around here to shake. I don't know that works, but then I don't know that copper bracelets help golfing injuries either. So this is pragmatic stuff. And the trouble is all of these exotic and colorful and wonderful treatment options, if they're not being covered, they're essentially not available. I mean, it's just that simple. They're not available.
Yeah,
And that stinks.
yeah. Dr. Gooden?
Yeah, so something important on that topic is that, if hypnotherapy sort of falls underneath the sort of umbrella of like psychological approaches to pain management and sort of pain practice therein, recognize that psychological therapies, much like medicines, much like interventions for pain, don't always work for everybody, right? So for example, when it comes to hypnotherapy, hypnosis being the key piece there, not everybody's going to be hypnotically suggestible, right? So if a person's not hypnotically suggestible, meaning that they're coming in very dubious and not really thinking this is going to work for them, it's probably not a good idea to go ahead and give them no anesthetic before you start cutting, right? However, for some folks, they are highly suggestible, and there are instances, you get experts like Guy Montgomery up in New York, David Patterson and Mark Jensen out in UW, where I've actually seen like a burn debridement done with nothing but hypnosis, right? And a burn debridement's pretty gnarly. So things like that can work. They just don't work for everybody. And two, I think sometimes just to think that like you're actively going to perform a surgery on somebody with nothing but hypnotherapy just freaks the general consensus out. And that somehow is not real medicine, and you shouldn't do that. And yikes, it's scary. So just go ahead and, hit them with Versed and the rest of the anesthetics that they need, knock them out, and then surgerize, right? But might hypnotherapy work for some people? Sure.
And I think you're getting into the whole area of models of treatment, acupuncture. I don't know much about energy meridians and those sorts of explanations of why naloxone and why acupuncture analgesia works. I mean, I think that it does, and we've got pretty good data there. But then all you have to do is to say, but it's naloxone reversible analgesia, and a light comes on and goes, oh, that does fit within my model. Naloxone reversing analgesia, that must be an endogenous opioid or something. Suddenly we've taken it from energy meridians and alien tech to something that's more comfortable to us. Doesn't mean that the analgesia is any more or less real. It just means that you're more comfortable explaining it somehow. I suspect hypnotherapy is somewhere in there. I mean, if that's within your model of being okay, then I'm guessing it would be more effective for you.
Mm-hmm.
Great. We had one last question that I was hoping to get to around, and I apologize, we've continued to get questions coming in the chat and in question format. We won't get to all of them, but hopefully we'll be able to have future talks as well to address these. Dr. Bailey or Dr. Gooden, any experience with low-dose naltrexone for neuropathic pain?
Not for neuropathic. It's been studied in several things. I mean, fibromyalgia is the one that I'm most familiar with. It does have statistical power that those studies did show that low-dose naltrexone helps. The trouble with those studies is, and you'd think, okay, well, that's harmless. You can't hurt somebody with naltrexone. Why not give her a try? The trouble is that the doses that get used are not available commercially. You have to have them compounded, and anything compounded flies in the same arena as the Tai Chi classes do. I mean,
no doubt.
If they can't get it paid for, I mean, I love compound. I used to do a lot of that stuff, but it's just not. It's not going to be covered, and therefore. But as far as working, I've not done much of it. Let me be more honest. I haven't done any low-dose naltrexone for nociplastic pain, but there are studies, and I know it's been tried. Saying, oh well, if it works for fibromyalgia, maybe it'll work for pick another condition. I don't think it's been studied quite as strongly in other conditions, but certainly with fibromyalgia, it's got some track.
Mhm.
Great, thank you. Any other parting words from our panelists on this topic or others that are related? Anything that you've seen in the chat even that you'd like to comment on?
I haven't looked at the chat, I'm afraid.
Ashley, any common themes from the chat that you'd like to bring to the attention of our panelists?
No, I think we addressed pretty much everything. Just lots of good feedback for Edward on hearing his perspective and his comments on the different questions. And then, lots of congratulations to Edward for his 4-year sober anniversary tomorrow. So.
Thank you, Ashley. One thing I was going to mention, especially for those of us in recovery, it's no secret that the treatment options in Alabama, at least, are not great all across the board. But as far as, and this is for those who are attending this, whether as a medical professional or just a person, who wants, resources, the ones that are there to help somebody get treatment or help yourself get treatment. You can go to our website, which is APC. I'll just put it in the chat box too, but it's apcbham.org. We used to be like a resource database just for this purpose. We've kind of evolved beyond that, but we still do that. So.
Thank you. Ashley, I wanted to ask you as the organizer, do we have time to take a couple minutes for folks who may need to stretch their legs between this and the next session?
Yeah, let's see. It's 1:58 right now. So can we plan to everyone be back by 2:05? All right, see y'all soon.
Great, thank you, Ashley.
And I'm gonna stop sharing here because y'all don't want to have Dr. Bar-Sinister staring you down.
I'll go ahead and put mine up there, I suppose.
And Dr. Bailey, lots of great comments and feedback for you. It seems like your presentation was much appreciated. I just want to make sure that if you don't have time to read, that you got lots of appreciation and love from the chat. So thank you.
I appreciate that. So very kind. Take a break myself.
It looks like we have hit 2:05. Dr. Gooden, what do you have on your computer?
I'm ready.
You're ready. And I apologize, I was late to the first hour. Did you all have a chance to introduce yourselves as a panel before the first session?
So I believe Dr. Bailey introduced himself, and then I was just going to do the same here as I move on into the slide, if that's all right.
Yeah, do you mind if Edward and I introduce ourselves for anybody who may have missed our interjection? Okay, great. And Edward, I'll put you on the spot after I introduce myself. Thank you all for joining. I'm an infectious diseases physician at UAB with an interest in addiction, specifically opioid use disorder. I do treat opioid use disorder in my HIV clinic. And work with the Addiction Prevention Coalition, who's a sponsor of this talk, in some of my work that's sponsored by SAMHSA on preventing HIV in young adults and youth who use substances. So thank you for being here. And Edward, do you want to go next?
Yeah, sure. My name is Edward Taylor. I'm the prevention program coordinator with the Addiction Prevention Coalition here in Birmingham, Alabama. I am a person in long-term recovery from, the medical term is opioid use disorder. I just call it heroin addiction. But I'm a person in long-term recovery. And I do have, on top of that, I have experience with chronic pain and not in recovery, thankfully, but before that, and it kind of merged in right on time with the development of my opioid use disorder. So definitely a pleasure to be on this webinar. I think there's some really, it might not be groundbreaking to the medical professionals on here, but to those of us outside of the medical field, it's groundbreaking stuff. So.
Thank you. And Dr. Gooden, do you want to introduce yourself and launch into your talk?
Yeah, sure. So I tell you what, I'm going to kind of minimize my thumbnail there. And if at any point you need to stop me or whatever, just holler, okay? So I am Burl Gooden, and I'm going to talk to the group here a little bit about pain psychology. It's what I'm passionate about. It's who I am. It's what I do. I'm a pain psychologist, but particularly in the context of sort of perioperative pain management to help minimize pain and opioid use following surgery. All right. Can everybody see my screen okay? I'm going to double check real fast. Thumbs up?
Looks great.
Sorry, like I said, I minimized it to a thumbnail, and then without any audible confirmation, I was stuck. Okay. All right. So obligatory, no financial disclosures or conflict of interest, right? I've got no financial skin in this game, just passion and lots of training. Again, because these are for continuing education credits, here's some learning objectives, right? So psychological aspects of acute and chronic, the transition therein of pain experience following surgery. I'm going to talk a little bit about psychological approaches to pain management. And then also the talk will be steeped in some of the more recent evidence regarding efficacy of psychological approaches for post-surgical pain management and opioid stewardship. Such that at the end of the presentation, if you're thinking a little bit more critically, or really just thinking at all about psychological approaches for pain management, for whom they might work best and under what circumstances, right? Using some of the knowledge that was presented here in this presentation, then I feel like I will have done my job for today. Okay, so this is actually then about me. As I mentioned, I'm a trained clinical psychologist, right? In the health track, which is the actual designated track for clinical psychology in the United States, I think beyond, but with the pain focus. So that's how I sort of refer to myself and market myself as a pain psychologist. I am an associate professor of psychology here at UAB. I saw that as people logged on to the talk that really there's representation across the United States. And I think I even saw some British colleagues. So that's pretty awesome. I'll try not to be too Alabama centric. I am the co-director of, I guess at this point, we're a little over a year old now, the new Center for Addiction and Pain Prevention and Intervention here at UAB called CAPI. As far as my training goes, my doctoral program was APA accredited, APA being the American Psychological Association, completed the designated or the obligatory internship, and then a postdoctoral pain fellowship at the University of Florida before relocating to the great state of Alabama. And I'm currently licensed to practice psychology in Alabama. Okay, so launching in here a little bit now to psychology. And the history of psychology is such that, you know, a bunch of old white guys that we may or may not be familiar with back in the day really started to talk about modern psychology, how it is implicated in health and has direct ties to neuroscience. The German gentleman there, Wilhelm Wundt, really kind of got it kicking. And then most people are familiar with Sigmund Freud over in Vienna. And he started to kind of really put psychology on the map. And then closer to home, William James really took up the charge here in the United States. The fathers of modern psychology, if you will, at the time, meaning like 1800s and early 1900s, it was modern psychology because it was actually mental health focused. I think, unfortunately, a lot of folks still sort of think that psychology is about laying down on a couch and telling me how your parents wronged you and how that stunted your development, caused trauma that impacts you today. And while there is a component of that, much like other aspects of medicine, psychology has really become specialized such that pain psychology is a thing. And if you look at some of this literature that's up here on this slide, you'll see that studies were being done in the late 80s and early 90s related to how cognitive behavioral approaches, psychological therapies could impact, hopefully in a positive way, and improve pain management, whether it was low back pain or rheumatologic conditions like RA, and even pain in the context of cancer. Okay. And then here, this is an older study, again, from the early 90s, really showing that you're going to get the most bang for your buck when it comes to pain management from these multidisciplinary pain treatment centers. Multidisciplinary meaning that it brings together your neurologist folks like Dr. Bailey, your pain medicine and anesthesiology interventional folks, pain psychologists, physical therapists, and social workers who hook folks up to resources that they would need to access treatments, things like that. The problem is that from just a financial perspective, it's really often cost prohibitive to run centers like this. So they've kind of gone the way of the dinosaur. Sometimes they'll bubble up, but oftentimes it's more of a niche practice where just a particular type of pain management will get done. If you do have a multidisciplinary pain treatment center like this, they often tend to be very urban in cities. Thus, people who live more suburban or rural can't necessarily access them. So you get disparities therein. But pain psychology as a component of multidisciplinary pain treatment centers, it's really kind of been known for a while now. Okay, I really feel like what has thrown pain psychology to the forefront of the front line on pain treatment has been some of the ongoing opioid misuse and abuse crisis and the epidemic therein. Traditionally, it's been that somebody with pain goes and sees their primary care physician. Primary care physician tries to provide some treatment. If that's not working well, then they may get referred to a more sort of secondary provider like, oh, you got back pain. Let's see if there is a slip disc or something like that. So there'll be some neurosurgery consult, something. Okay, that's looking good. We can't quite figure it out. Now you're getting referred on to tertiary care, which is pain management in and of itself, or pain medicine, usually anesthesiology run, or you see Dr. Bailey there. And then at that point, maybe then you get referred to the pain psychologist. At that point, it's been a 2-year process. The pain has kind of been more and more chronic. The patient's been put through the ringer, and ultimately then you need to see the pain psychologist. They're led to believe the pain's all in your head. They're pissed off. They're feeling stigmatized, and they really don't want to see me anyways. Excuse me. Now, with some of the opioid issues, the question is it important to really have pain psychology at the tip of the spear, which is often primary care, right? And these overdoses and things therein, when oftentimes their first exposure to pain management may be an opioid pill, it's kind of changed the tone of things, right? This slide, not to harp on it too much because Dr. Bailey just presented it, is really to just emphasize the fact that in the late 2000s, the opioid epidemic was really ramping up because the pendulum of opioid use for pain management was swung in the direction of it's a wonder drug, prescribe the crap out of it, give it to everybody who needs it. Because of that, some nefarious practices popped up, such as pill mills, problems therein. There got to be a lot of cracking down at the level of DEA and a lot of oversight, such that over the last 10 years, the pendulum has swung the other direction, where there's a lot of patients who are doing what they need to be doing and using an opioid responsibly, but they're still having the rug pulled out from underneath them because there's a lot of opioid phobia for fear of providers being audited by DEA, so forth and so on. This slide, I think, represents that insofar as that after about 2012, when you look at the light blue line, the prescribed opioids and the overdoses therein started to plateau and then decrease. In 2012, 15, 16, 17, heroin ramped up. That was the issue, but it's also sort of decreased over the last couple of years. Again, COVID-related issues notwithstanding in terms of what's happened in 20 and 21, but where you see the huge uptick is still the synthetic opioids. That is illicitly manufactured fentanyl, right? So again, a lot of opioid-related overdose deaths right now are being driven by, again, illicit street-level synthetic opioids, right? There's a lot of good opioid stewardship going on in the responsible use of opioids for pain management. I just wanted to put that out there as a disclaimer, not to belabor it too much. Okay, so as it relates to getting a little bit more to what I was talking about and the nature of this discussion is access to prescribed opioids in the context of having some type of surgery, right? So recent evidence suggests that surgical patients are nearly 4 times more likely to get sent home following their surgery with an opioid than non-surgical counterparts. So for example, people who visit the ER and get admitted to the hospital through the ER, again, surgical patients 4 times more likely to get a post-discharge opioid. Orthopedic surgeons alone were responsible. Now, again, this is a little bit dated, but some of this is like public health epidemiological data, and there's a bit of a lag there. But for orthopods and the surgeons therein responsible for 7.7% of opioid prescriptions back in 2009. So over 6 million people being sent home with an opioid after their surgery from their surgeon. And this is not to pick on orthopedic surgeons, because by and large, the vast majority of people who are opioid naive and have been prescribed an opioid are coming from primary care. But it just shows that this is a potential sensitive spot for people who have never been exposed to an opioid to come through, get some sort of surgical intervention, and potentially be sent home with an opioid. And if that isn't done in a responsible manner, could potentially cause an issue in perhaps one of 2 ways. 3 to 10% of opioid naive patients become chronic users post-surgically, okay? Up to 80% of prescribed pills in the remaining groups of patients are unused. So that's a lot of opioids that are perhaps sitting around unused in medicine cabinets that could perhaps be taken and diverted by family members or people, children, inadvertent sort of exposures therein, right? So just keep that in mind. I'll stop there for a second with this green slide, because I think that there may have been a question from Edward, or we want to take provide an opportunity for questions from folks.
Yeah, sure. So I didn't have any questions, and I'm going to have to be careful to pace myself, because when I read your slides to prepare for this, Dr. Gooden, my head kind of exploded with all different kinds of ideas and thoughts. But again, I mentioned this earlier, but that last slide, what's really a huge concern, definitely for me and my job and us at the APC, and surely most everyone, is that unused supply that lingers around. One of the initiatives that I work on here at the APC is getting rid of those. Obviously, we can't go to everybody's house, but we try things like drug disposal kits, getting those to treatment centers so they can give those to loved ones when they drop their family members off, getting those to hospice centers, things like that. But, bigger picture, again, trying to pace myself is I was, in my experience with chronic pain, I was not offered, not once that I'm aware of, any pain psychology treatments, pre-op or post-op, because I did have 2 operations. I don't know, I'll get more into that as we hit these Paul's slides. But, another thing I thought of is effective post-op pain psychology could definitely help with that street supply of unused opiates or opioids. Because if you have somebody who is confident in their doctor's plan for their pain afterwards with predominantly pain psychology, and they're given a kind of a rescue emergency prescription of like 6 Norcos, for example, or whatever it is nowadays, even if that person doesn't touch it and they forget about it, that's only 6, so that's obviously none would be ideal, but 6 is better than 120 for sure.
Yeah.
I think it's worth saying here that the surgeons understand that this is a problem, and a lot of the surgical groups, I think the ones in Minnesota, have gotten together and put these tables together of what's the right number of, pick a pill to send your patient home with following, and then a laundry list of common orthopedic procedures that they do.
Yep.
And they're fairly small numbers, they're 5 and 6 and 10 and that sort of thing. So, kudos to the orthos guys for doing something. I mean, that's not going to get stuff out of the cabinets that's already there, but they do at least recognize that problem, because it is a problem. You're right.
I would agree. And that's actually a nice segue into this slide, particularly because this study was done by Bratton colleagues a couple of years ago, right? And what they did is they went into like insurance claims data, stuff that was collected for, I think this was through Kaiser and a lot of other providers, over 37 million different claims that they could mine to look at post-surgical prescriptions and sort of misuse and abuse issues for opioids therein following surgery, right? So there was 37 million different claims, right? Over 1 million people who were opioid naive and underwent a surgery. And this could be anything from like a pretty invasive surgery to like thoracotomy to something a little less invasive and a little bit more routine, like an appendectomy, right? But of these 1 million people who underwent a surgery, over 500,000 received post-surgical opioid prescriptions, okay? And then they sort of identified what would be considered an opioid abuse, and that was an overdose or some sort of opioid access behavior, right? That was considered to be more abusive, right? And it's, again, it's in the paper, but the point being is roughly 6,000 opioid abuse cases, right? So they were trying to predict of these people who got the opioid, how many had this abuse and what was like sort of the defining things that predicted that, right? And really what they found was that for use of oral opioids after discharge determined by refills, total dosage, and duration of use was particularly predictive of who had the opioid abuse issue, right? So the key factor here, and make sure I can see what's going on here on my slide, is that each refill or each additional week of opioid prescription following the surgery was associated with a pretty large increase in the likelihood of opioid misuse. Importantly, it wasn't actually the dosage, right? So the dosage, and this is something that ends up being a big sort of sticking point in terms of MMEs, right? Morphine equivalents. And there's CDC guidelines and that are just guidelines, but are being like uptook. it's not the right word, but you get what I'm saying, right? To sort of guide practice, right? Where it's like, well, we couldn't send you home with more than like 90 MME equivalents a day. This study suggested that it's not necessarily the dosage itself, but how many times people are being exposed to the dose in terms of refills that make, really increase the risk of a problem. So that's good data, right? Importantly, though, as it relates to pain-related sort of opioid usage problems therein, the NIH has recognized this problem and has done two particular things. They've created the NIH HEAL initiative, and HEAL is actually an acronym for helping to end addiction long-term. And this is sort of the research arm where they want to fund studies to develop new treatments for improved opioid misuse and addiction therapy, and then also enhancing pain management. And then more on the policy and applied side for clinical practice guidance, the national pain strategy, right, for developing really sort of like nationwide programs for effective pain management, standardized sort of assessment treatments therein, keeping in mind that much like any sort of medicine, there needs to be latitude for precision, right? Because medicine generally, when it's applied one size fits all, doesn't really work because there's people, we treat people, not averages. And a lot of the studies are done on averages, okay? Just to sort of emphasize like ongoing issues related to pain in the context of surgery, 2017 was the International Association for the Study of Pain's Global Year Against Pain After Surgery, right? And there's a lot of good resources that are available at this link here for ISP. A lot of people doing pretty good work on establishing guidelines for things like management of postoperative pain here. There hasn't been a whole lot of emphasis and research dedicated to pain psychology in this context. So the question that I pose is like, well, what can pain psychology specifically do to help manage pain postoperatively, right? Well, to better appreciate why there's even a role for psychology, we have to appreciate that for the longest time, assessment and treatment of pain has kind of adhered to this biomedical model of pain that was put forth way back in the day by René Descartes, right? That was very sort of reductionistic, really emphasizing that pathology, physiology, and biochemistry have to be the reason for the pain, right? And that the amount of tissue damage is directly proportional to the amount of pain experienced, right? And we now know, especially that that's not the case, right? Because there can be instances where, so for example, a person has surgery and it makes sense that they're experiencing pain at the site of their surgery, right? For example, if they have their knee replaced, right? And then everything heals up, and for all intents and purposes, that new knee, right? That synthetic knee looks good, but they're still experiencing chronic knee pain. Well, why is that if the reason for the pain has been removed, right? And that's where issues related to nociplastic pain come into play, like Dr. Bailey said, where there are things related like neuroscientific, neurophysiological changes at the level of peripheral and central nervous system that can maintain pain even when the initial generator has been quote unquote fixed, okay? So that lends itself to the biopsychosocial model of pain, which provides much more leeway for the psychology to impact how people develop pain, but also can treat pain therein, right? Okay. And here's just the schematic really showing how all these factors interplay to impact a person's pain experience, potential transition from acute to chronic pain, and then also how making inroads from a treatment perspective on, say, the psychological aspect can actually have impact on biological processes that underlie pain, so forth and so on. So this fear avoidance model of pain development is a pretty characteristic or a pretty like quintessential pain development schematic that psychologists like to sort of emphasize, right? So for example, there's an injury. In this instance, it would be basically like surgery, having your knee replaced or a thoracotomy or some sort of surgery, right? There's going to be a pain experience. The vast majority of people, right, will take whatever treatments, right, that are prescribed to them, whether that's anesthesia, different medicines, an opioid, right after that surgery. They're going to confront the pain they're in. They're not really going to be terribly fearful of it, right? They're going to do whatever rehabilitation they need to do. They're going to recover. They're going to go on about their business. A significant minority of individuals are going to go the opposite direction. And what's going to happen is that they're going to experience that pain. It's going to be met with their lived experiences and their sort of psychological overlay such that they may catastrophize. And if you don't know that term, hold tight because I'll explain it a little bit. If they're depressed or if they don't have good social support, it's going to hamper their recovery. But there's going to become a fear of pain. And because things like getting up and moving around may elicit greater pain, for example, in the context of like having your knee or hip replaced, they're going to avoid movement. They're going to try to escape things that would cause their pain to become greater, or even escape like situations that may stoke the fear of that pain. They get into a loop of disuse, and if you don't use it, you lose it when it comes to things like muscle tone, so forth and so on. That promotes disability, depression, and you get stuck in this loop whereby that acute pain can transition to chronic pain and then only, become more chronic and debilitating thereafter. Thoughts therein, question? Thoughts therein, question. Questions about what I just said?
I don't have any questions, but a few remarks I had prepared for this pulse slide. It's really interesting throughout this whole presentation. A lot of all of the research that's in here validates like every experience I've had, medically, especially, but I can say that, and you'll touch more on this throughout the rest of your presentation, but my mental health diagnoses, unequivocally impacted my pain level. I'd say it may have even been the majority of it, the gas on the fire for sure.
Right.
And I'm again not an expert, but when I was reading this, the biomedical model, I think you were saying, basically makes kind of like an objective assumption, sort of based on like an injury equals this much pain. And that was something kind of that mindset was something when I started to become truly addicted, I would take advantage of that because I would just go to a different doctor and say, well, look at that x-ray and you see that stuff in my neck, it hurts. I want more medicine. And also one thing I haven't made clear yet is I definitely don't, for any of my experiences, and I don't place the blame on any medical doctor or surgeon or therapist, nobody, I take responsibility for it. That's just the healthiest way to go about it. And then also, throwing Descartes in there, that my bachelor's is in philosophy, so I feel like that's sacrilegious. Maybe he's responsible for my addiction. I don't know, but I'll let you keep going.
Yeah, fair enough. All right.
Dr. Gooden, I wanted to add one comment that I see in the chat.
Yes.
Someone brought up that there needs to be better collaboration between pharmacists and clinicians. And I'm curious if you have that in your practice or if you have any suggestions. I think it's a great suggestion. We've talked about limited resources here in the Deep South, but if you have any comments along those lines.
So absolutely, right. So there absolutely needs to be, as much as I hate to say it, those collaborations come down to dollars, right? Because any sort of collaboration, meaning like, medication review, if I'm the pharmacist, I need to get on the phone and either consult with me or Dr. Bailey. That's my professional time. And I need to be able to recoup costs for that, right? That's just how it goes. And unfortunately, I don't think there's a good sort of reimbursement model or a way to facilitate that collaboration. That's not to say that pharmacists aren't good people doing this work, but oftentimes if they're doing it, it's above and beyond. They're paid 9 to 5 so that they're on the phone at 6 o'clock at night and they just missed their daughter's T-ball game and now they're pissed off about it. And they should have done a few more like checks and balances, but they got to hurry up and get off the phone. So again, collaboration absolutely needs to happen. but there also needs to be a way of like saying, hey, I spent an hour of my time collaborating with Dr. Bailey and Dr. Gooden to get this right. And how do I get compensated for that fairly? You see what I'm saying? And I don't really think there's a good way. And that's regardless of like Medicaid expansion or not. There's not a good way for that to happen right now. And I hope some of that can be sort of taken care of by people who are smarter than I.
I will say that there has been effort to coordinate with pharmacy and industry. I was on a AMA task force. I don't know, it's been several years now, where the CEO of Walgreens and the DEA and a lot of people were there. And it's pretty enlightening. The pharmacists are on the hook. I mean, they truly are. I mean, if all night pharmacy in Florida, if you walk in with a script for, big bag of OxyContin at high milligram doses, he's on the hook. If he fills it and it smells bad, then he's on the hook as well as the doc that wrote the thing. I mean, they have language, in the usual course of medical practice and all that stuff. I can't remember the specifics, but you're absolutely right. It's a tough issue, because what's he going, pharmacists were at one time wanting diagnoses or diagnosis codes to be put on prescriptions. And docs got all fluffy about that. What the hell do you mean? I mean, is he going to argue with my diagnosis now and not fill the prescription based on, what the pharmacist, that's out of his scope of practice. And it's a very thorny issue.
No doubt.
We created several education programs, but I don't really think it went much further than that.
Mm-hmm. Yeah. But and when it comes to that multidisciplinary pain management model, I mean, pharmacists 110% have a place at the table, and that coordination, really needs to include them. Yeah. All right. Let me see if I can move on here. Come on, slides. Advance, please. Seem to be a bit stuck. I'm gonna stop sharing and share again. I just got stuck. Participants can now see my application. That's great. And sorry, folks, 1 second here. Oh, here we go. Okay. Excuse me. I think I was getting too many emails, and then this was up, and then my little laptop here had like a log jam. So really, to get into pain psychology stuff, I mentioned pain catastrophizing, right? And thus far, with the research that's been done, pain catastrophizing is really the most robust psychological contributor to negative pain outcomes and things related to opioid issues, right? And pain catastrophizing refers to an exaggerated and negative sort of cognition, sort of mind frame related to the actual or anticipated experience of pain, really thought to be sort of subsumed by things related to magnification, or really just sort of like, again, as the name would suggest, putting a magnifying glass on the pain and thinking about just how much it hurts. The rumination, right? Not being able to think about anything else and just anxiously awaiting for it to go away. And then ultimately helplessness and feeling like there's nothing that can be done to reduce the intensity of my pain. And like the little cartoon shows there, here's a person with back pain, right? And this will speak to, I'm going the wrong way here, sorry. Back pain, speak to Dr. Bailey's practice of he's sitting there in his chair thinking about how catastrophically in a couple of years, I'm going to be wheelchair bound. I'm going to lose my job and I'll have no income. My wife's going to divorce me. My family's going to kick me out of the house. I'm going to be on the streets. And the downward spiral continues, right? In terms of thinking, and that has negative ramifications for the actual pain and functionality therein, right? So here's just some research to show you that Pain catastrophizing has really been shown to predict transition from acute to chronic low back pain. It's been shown to predict greater pain intensity and duration following a host of surgeries. Poor adjustment to knee amputation and phantom limb pain that can present thereafter. In the opioid realm, pain catastrophizing, it's been shown that people who actually have greater pain catastrophizing have poor responses to opioids in terms of the analgesia that they derive, which is interesting. People with greater pain catastrophizing demonstrate greater use of their opioids following surgery. There's more misuse of opioids when people who have greater pain catastrophizing, and more persistent pain and pain chronification following surgery and things like that. Again, speaking to sort of psychological aspects of who has chronic pain following surgery, this was a study that was done in people who experienced knee replacement. And that's an important one because one, it's one that gets researched a lot. Also, there's a lot of knee replacements, hip replacements, joint replacements that are done. It's common for those people to be experiencing a lot of pain leading up to the surgery. Conversely, things like breast surgery, if there's a person who has, let's say, a lump and needs to have a lumpectomy or a total mastectomy, oftentimes there's not pain that is present prior to that surgery. But what can happen then afterwards is that they can develop post-surgical pain. So in this particular study, those who were experiencing pain 3 months after their surgery, and that pain was greater than 3 on a 0 to 10 scale, were older individuals, people who had greater post-surgical pain on day 2 following their surgery, those who had a diagnosis of anxiety and were more anxious just in general, and then those people who had greater pain catastrophizing, particularly that magnification component of pain. And the results suggested that prediction of postoperative pain really didn't differ as a function of the surgery type, where conversely, an additional study, this one here, suggested that like pain catastrophizing and anxiety were predictors of arthroplastic pain, following knee arthroplasty, as well as like lumpectomy and mastectomy pain, but that it differed as a function of who had some pain preceding the surgery, right? And again, the thought just being is that there might, the anxiety, the catastrophizing may be a little bit more pronounced if you've been actually experiencing pain leading up to your surgery, which again would lead itself to a little bit of a worse outcome for people who are having like bad knee OA, hip OA, and then have to have a replacement, as opposed to somebody who had no pain preceding their surgery and then went on to develop chronic pain afterwards. Similarly, risk factors for continued opioid use, greater pain catastrophizing, greater anxiety, the presence of post-traumatic stress disorder and depression, right? And this is in the context of who had some sort of musculoskeletal trauma with surgery to fix it, so a broken bone, something like that. But the single best predictor of issues with opioids following the surgery was pain catastrophizing. Okay, so this speaks to the fact, like, are there psychological treatments that can mitigate and minimize pain catastrophizing? And the answer is yes. They were initially developed for chronic pain such that they might get rolled out by a pain psychologist like me over the course of like 8 to 10 weeks. That's a long time, right? So there's been a lot of efforts to see if like these treatments can be distilled down into, say, like a single session that maybe takes an hour or two as part of like a workshop that could be done before a surgery and then help limit the amount of pain and opioid exposure a person needs in order to get back on track following surgery. Somebody who's really helped like put this on the map is Beth Varnell out at Stanford. And if you look at the bottom citation here, from catastrophizing to recovery, she's done a lot of work trying to create this single session pain psychology intervention focused on minimizing pain catastrophizing in an attempt to improve postoperative pain and opioid outcomes thereafter, right? So here's just a little bit of some of the research that's been done on the topic. So this was a study that was done using CBT to actually minimize depression following coronary artery bypass graft surgery, because depression is known to be related to mortality thereafter. So depression was the initial primary outcome, but then they came along, we're like, well, secondarily, we were related to pain, chest pain that is, related to these coronary artery bypass grafts. And what you can see is relative to usual care, meaning they didn't have the CBT, those people that got CBT showed decreased pain severity, pain interference, and greater perceived control related to their pain. So here's some indirect evidence suggesting that CBT can really be helpful for postoperative pain in the context of coronary artery bypass grafts. Same sort of deal here with, and one of the issues I dislike about my profession is that this group calls it CBT. This group calls it a mind-body skills-based intervention. This group calls it just psychological therapy. It's kind of hard to know what is what because we don't have standardized terms. By and large, it's kind of comparable material though. But in this study, of a mind-body-based intervention for patients who underwent orthopedic trauma or who experienced orthopedic trauma, right? The important piece here is that in the table, the PCS is the pain catastrophizing scale. On the left, the RRCB is basically what their catastrophizing score was before this mind-body treatment and then after. And you can see pain catastrophizing went down a lot, right? For the control group that didn't get this mind-body skills-based intervention, pain catastrophizing basically stayed the same. Right. So again, to the extent that we feel like pain catastrophizing is really conferring a lot of risk and problematic pain and opioid use outcomes following surgery and corrective procedures for orthopedic traumas, there's some suggestion here that psychological therapies may help decrease pain catastrophizing, which in turn is going to improve these postoperative outcomes. Some folks are actually kind of taking and melding together pain psychology, right, in the form of cognitive behavioral interventions and mixing them with physical therapy or other non-pharmacologic interventions, and that's what was done here. So this is a CBT-informed physical therapy intervention that was rolled out to 8 patients who underwent surgery for lumbar degenerative conditions. So this is like laminectomies and disc fusions. They completed 6 sessions of this integrated CBT physical therapy. 7 of 8 patients demonstrated clinically significant reductions in their pain 6 months after treatment, and all 8 had significant reductions in disability. So this is interesting to sort of show how a lot of these treatments can be sort of streamlined into a single sort of encounter with, say, a physical therapist who's been trained in some CBT. Don't tell my psychology constituency, but like the stuff that we're doing, it's not rocket science, right? So like, even though I'm a pain psychologist and I'm trained to do this, non-pain psychologists can often be trained to do this as well. And it's super important, I feel like, to do that because just to tie it back to Alabama, there's like barely over 2,000 psychologists licensed to practice in the entirety of Alabama. And to my knowledge, I want to say that maybe 24 of those are pain psychologists like myself. So if ultimately we're the only ones that can do the CBT, there's going to be a huge shortage of people like me to deliver this treatment. So we got to figure out who else can do this stuff. And I say social workers, nurses, physical therapists, you know, things like that. Okay. Cognitive behavioral therapy is one type of treatment. Another type of treatment is what's called acceptance and commitment therapy. And I'll try to get to that here in a moment in terms of differentiating what's what. But ultimately, this just goes to show that from Barb Rakel's group up in Iowa and some of her folks at Vanderbilt, that acceptance and commitment therapy relative to just treatment as usual, right? Following, I can't remember exactly what the surgery was here, right? But the point being is that the acceptance and commitment therapy, those patients had quicker time to their pain being under control and cessation of opioids, right? So acceptance and commitment therapy is another sort of psychological therapy known to be helpful. Let me just stop here. Questions about any of that data? And if not, it's okay. I kind of, like I said, I just wanted to quickly sort of differentiate what psychological treatment looks like, but I may not be able to get to it. I want to be mindful of people's time. I've overestimated how quickly I'd move.
It's not specifically for that data, but I just wanted to squeeze a few things in and then let you wrap this up, Dr. Gooden.
Okay.
But a big thing, the reason why I said earlier that this kind of treatment would have been helpful for me just as much pre-op is because, even though I know we're talking about post-op, is because a big part of my situation was catastrophizing.
Mhm.
So I thought that, this pain that I've had for oftentimes severe that I've had for, a year and a half, there's just no way it's going to go away. I don't have any evidence to suggest otherwise after all these things I've tried. So what happened was, even though the first surgery didn't work, the second one did. And, but I had this habit built, okay, well, there's still some pain, and it's not going to go away. So I need to take the opiates again. And then eventually that pain did go away. But then I was like, well, now if I stop, I'm going to get sick, so I better keep going. And of course I really enjoyed it too. So I was addicted at that point, but
Sure.
that just extends the kind of the duration of the use, which just increases the likelihood of, becoming fully blown in opioid use disorder. But another thing that I mentioned earlier, it seems like the challenge that I can think of is convincing folks, especially with kind of long held chronic pain, that this is helpful, that this is going to help them. Because even if I didn't have an opioid use disorder when I was going through all this, even if I didn't have that, I probably would have balked if someone had suggested to me, hey, let's try some CBT, which I would have known what that is.
Yep.
I'm thinking, how is that with this, structural pain in my body? Like, how is that going to do anything?
Yep.
And then you're going to get to this next part in a second, and I promise I'll be finished. But the treatments that you're going to mention, that like mindfulness meditation and stuff like that. My experience that's pertinent to that field is that I've had real kind of immediate pain relief and recovery to different painful situations, like muscle tears or a really bad headache. And those are a huge help with my mental health diagnoses, and body scan meditations in particular. Those have been remarkably effective. Even if it doesn't, if it starts with what's going on up here and that trickles down to whatever is going on with my body, those body scan meditations are awesome. But you'll mention too, actually, I'll cut it there. I'll let you.
Okay. All right. Well, listen, I'm gonna fly through this piece for the sake of time, which means, unfortunately, I'm probably not going to do it justice, but just to make sure that I get through this. And if there's any burning questions at the end, right? Let me just say this. What does psychological treatment for pain look like? First and foremost, the cornerstone of it is compassion and a strong therapeutic alliance, person-centered, right? If I'm a pain expert, that's great, but I'm not an expert in a person's lived experience. I need to know what's going on, right? Pain is a subjective experience. So just because I think I know what's happening based upon what I read, I need to hear what's happening from your perspective, right? So there has to be good rapport, because if it's a chronic pain condition, you're going to come back and see me. And if you don't like me, you're not going to come back and see me anymore, right? So I need to be able to relate and connect, okay? I'm going to move past that. Stigma is a big thing that a lot of patients experience, whether it's getting people to believe that their pain is real or around opioids, right? Because they help. I'm not an addict just trying to get high, right? So we need to find ways to minimize stigma, right? Managing expectations for just pain management and letting people know that they got to put some skin in the game, as Dr. Bailey was alluding to, right? So it's a self-management condition, much like, a person might go to a doctor to get help with diabetes, hypertension. Ultimately, they need to do the things to keep their A1C low and their blood pressure in that, kind of good range. Same sort of thing with pain management, right? A lot of it's said and done with what are you doing or not doing to help yourself. Cognitive behavioral therapy, education, right? Somebody says you might need to see the psychologist to help with your pain. People are like, whoa, 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 my pain's real. We need to educate how there's a psychological influence there. One of the hallmarks of like CBT is knowing that you're having some maladaptive and unhelpful thoughts. How do you change them to being more adaptive? Okay, that's the hallmark of that. It works for a lot of people, right? Changing your thoughts can change how you behave and then how you feel. However, for a lot of folks, if I say stop thinking about something, they think about it more, right? And that makes it challenging, which brings in acceptance-based therapies, which is not about changing your thoughts. It's just recognizing your thoughts for what they are, just thoughts. The work is actually diffusing the thought from any sort of emotional valence it might create, such that, man, this pain might never get better. Well, that's a crummy thought, it might not. It may actually get better, who knows, right? That's tomorrow. Tomorrow isn't promised. I need to focus on this moment because it's the only one promised to me. And you maintain psychological flexibility, and that's the hallmark for acceptance and commitment type therapies, right? Mindfulness, meditation, that's kind of in vogue right now, is a hallmark for this sort of therapy. And that's the stuff that pain psychology will help a person become more proficient with. So I'm just going to stop there. I think entirely stop sharing my screen. So that way, if there's any last minute burning questions, I might be able to answer them before we need to break because people's time is valuable and they need to move on. So by any means, by all means, if there's anything folks want to ask, let it rip. I'm sorry, my speech is pressured. I'm adamant about this stuff and I was going for it.
Daryl, I see a really interesting question around trauma and your thoughts on the role of trauma in pain perception.
Okay. So this is something I've been grappled with because I feel like as we've started to acknowledge all the various ways that people can be traumatized, there appears to be a big sort of like influx of trauma and people like owning that or whatever. I also feel though that like trauma is kind of a trendy word, and sometimes people will use trauma in ways, honestly, that I don't think that they should. It was like, oh, that, like I had a student that was like, that test I took was traumatizing. I was like, was it hard? And maybe should you have studied harder? Perhaps, but like, is that a trauma? Right? But like trauma, right? Like whether that's horrible things that, adults will sometimes perpetrate against kids, or one person will perpetrate against another, or Mother Nature or some sort of catastrophic event will perpetrate. That sort of trauma is not going to do pain any favors, right? Because the other thing too is that in the context of, say, sexual abuse, physical abuse, emotional abuse, I would argue that that sort of trauma stems from one of the most horrible ways that you can be sort of excluded, ostracized, taken advantage of by the humankind, right? And because we are inherently social beings that want to trust, want to build connections, that trauma is going to undermine that. And that's a threat to our very existence. That sort of social pain does nothing positive for physical pain. I say social and physical pain, that's a false dichotomy because the brain only knows pain, but just to sort of indicate where that pain may arise from, trauma-focused therapy is a thing, all right? So I just want to say that it's super important. Can't emphasize it enough. Hopefully I did justice for that.
That was great. I think, lots of great questions, lots of great comments. I'm seeing everyone's comments from Scotland to Canada to the UK. We're so grateful and appreciative that you all joined us across time zones and continents. And I know that we'll be sharing with the listserv our slides and the presentation itself. Feel free to share. And I think with such a tremendous showing, we'll have to revisit this and come up with additional sessions. So I want to personally thank Edward, Dr. Bailey, Dr. Gooden. I learned a lot, and based on the comments and questions, it sounds like others did too. Ashley, any housekeeping issues that I missed?
Yeah, So once again, thank you, Dr. Bailey, and thank you, Dr. Gooden and Dr. Eden and Edward for being on here today. I'm going to put the link to the evaluation in the chat. I just put it in there. So you should just be able to click on the SurveyMonkey link and it will take you to the evaluation. And then, like I explained earlier today, the CE request form will be at the end of the evaluation. So just click on that. And then if you have any questions, I'm going to put my email in the chat as well. All right, but that's all I've got. Thank you, guys.
And if anybody wants to contact me, go for it, right? I'm easy to find. If you just Google my name or whatever, I'm on Twitter now. I'm not terribly Twitter active, but hey, I'm on Twitter or whatever. Like, I enjoy talking about this stuff, so contact me.
All right, excellent. Thank you.
All right. Thanks, everybody. Always a pleasure, Ellen. Thanks so much. Thanks, folks. Have a good one.
Thank you.